Hi, Karen. Great to see you. We haven't said hello. I've already said hello to Jessica and to Kingsley, who will be the home team, the UCT team today. So welcome from Cape Town to everybody who's signing on. It's a great privilege to have you with us. We're having a very, very lovely topic today. And I am going to hand over to Prof. Jessica Opie, our colleague, head of hematopathology. She is very, this topic is something that she's been working on for and been confronted with for many, many years. But there's a lot of stuff that's changed lately, and I think that is what Kingsley as well as Karen will be chatting to us about. It's a difficult topic. I am not going to say much more about that, except that we are also very happy to have some of our colleagues in private here today, but more from Jessica about that. So with that, I hand over and really look forward to this afternoon's session.
Thank you very much, Estelle, and welcome everybody. Indeed, this is a challenging area. In fact, we will be focusing on some updated guidelines that were published about a year ago, just over a year ago in Blood, regarding the technical assessment of minimal residual disease in acute myeloid leukemia, which is really a very challenging area. It's not as yet well standardized, either abroad or in South Africa. But we'll be talking about what the guidelines are and what we are able to achieve, what is currently available. The interesting thing is that even despite these limitations in standardization, a big meta-analysis published in, I think it was The Lancet, documented that if we can demonstrate MRD by any method, doesn't matter which, in AML in patients that are in morphological remission, there's proven impact on their survival. So it really is a very important area. And I'd like to welcome Kingsley Lowland, who is a new hematology pathologist with us at UCT. We've been delighted to have him. He started with us in January, so he's newly qualified from Tygerberg, and he's going to be focusing on flow cytometry in AML, and it's now called measurable residual disease, not minimal residual disease. They've changed that term. And I will stop him after about half an hour just to get some comments from Theo Gerdener, who's joining us or has joined us from Oncolab in Pretoria, to get some perspectives from the private sector. And I hope that Henri Dupisani from Pathcare will also be able to provide some comments at that juncture. And then Kingsley will continue his talk, and after he has finished, Karen Shires will provide some perspectives on the molecular monitoring of measurable residual disease in AML. So I'm really looking forward to the talks, and Kingsley, over to you. Thank you.
Hello, everyone, and welcome. I'm just going to start sharing my screen. So I'm just checking now, can everyone see and hear me?
Yes, Kingsley.
Okay, sure thing, great stuff.
I think, are you on presenter view?
I am.
We're seeing two slides of your presentation. So it's not in presentation mode, I don't think.
And now?
Now that's working, perfect.
Okay, sure thing. So I'm just going to just stop my video just to save some broadband. Okay, so good afternoon, everyone. So I'll be chatting to you guys about the flow cytometry aspects of measurable residual disease in AML. So okay, there we go. Okay, so just sort of the content that I'll be covering. So I'll just give a little introduction. I'll go through the importance of MRD, where, when, and with what. And then I'll cover just the ELN 2021 flow cytometry recommendations. And then after that, I'll go through some of the flow response and relapse, as well as some of the thresholds. And then I'll talk briefly about what we do here at Groote Schuur Hospital in terms of AML MRD. I'll go through some of the time points for MRD monitoring and the definitions of the MRD response and relapse, some advantages and limitations of using flow for MRD. And then I think sort of, I think the question that everyone has is it clinically actionable, and does it portend any fate? And then just lastly, I'll close with a bit of concluding remarks. So AML is typically widely disseminated at initial diagnosis. The key issue in assessing post-treatment response is how accurately the evaluation of a small sample of the patient reflects the total remaining leukemic burden, with the capacity to lead to a subsequent clinically evident relapse. And an insufficient sample or a suboptimal assessment of a sample post-treatment may lead to a false reassurance that a patient in complete remission has achieved a state of disease clearance. And this concept is quickly shattered by the relapse that follows. So it has been stated that the most pressing problem in AML is relapse. However, a reasonable counter-argument to this is that AML therapy is suboptimal and appears adequate only due to insufficient stringent response criteria. But there has been leaps and bounds with regards to AML in general, both in its in our workup of understanding all of the molecular mutations involved, as well as in the development of treatments in AML. So starting from the 1960s all the way to 2018 and even till now, there has been much more advances in the in management, from our standard 7+3 to the introduction and then sort of the withdrawal of gemtuzumab ozogamycin, which is an anti-CD33 monoclonal antibody, to the introduction of our hypomethylating agents such as decitabine and azacitidine, and the lyophilized 3+7 CPX351. And then as we understand the molecular landscape of AML, the newer treatments such as your IDH1 and 2 inhibitors, and then your FLT3 inhibitors such as midostaurin, and your newer generations such as gilteritinib, as well as hedgehog pathway inhibitors such as glastaglib. So, you know, as you can see from this flow diagram over here, there has been quite a lot of advances within the treatment of AML. So the ELN in 2017, as well as in 2021, updated the response criteria in AML with an addition of a best possible response category called complete remission without MRD, or CR-MRD negative. So general MRD assays, analytical tools, and reporting standards all require standardization and harmonization. And it is important to evaluate to evaluate each measurable residual disease approach for clinical decision-making, taking into account the turnaround time, the cost, the sensitivity, and effects of clonal evolution between these assays. So at the moment in our armament for MRD, we have multi-parameter flow cytometry. And then on the molecular aspect, we have next generation sequencing as well as PCR. But currently there is no one best test for all cases of MRD in AML. So for 40 years, the concept of MRD in AML exists and may be detectable and treatable. But in the past 5 years, systematic reviews and meta-analysis have demonstrated that regardless of the MRD methodology used, patients testing positive either at a specific time point prior to allostem cell transplant or more generally at any time during treatment have worse survival than those who test MRD negative. And this stratification at the cohort level can assign patients with AML in complete remission after treatment into groups with either higher or lower risk of subsequent relapse. However, when currently measured at a single time point, MRD testing is suboptimal at an individual patient level for relapse prediction, particularly when baseline disease and disease characteristics are considered. And achieving MRD negativity in AML is an important signifier of response to initial treatment, but additional evidence is required to determine if this is the most appropriate goal, and if so, the best ways to get there, both on an individual patient as well as an international community. So just some of the important points around MRD. So it is clear that MRD is possibly the gold standard for assessing AML response criteria. However, logistics associated with widespread harmonized clinical implementation remains to be defined. And there are several technologies available for MRD quantification, but the assays and reporting lack standardization and comparability. Detection of MRD by any methodology during morphological remission after standard chemotherapy is a strong prognostic factor for subsequent relapse and the short-term survival in patients with AML. And MRD may have value in guiding treatment, in guiding post-remission therapy and identifying early relapse, and as a surrogate endpoint for clinical trials to accelerate the development of novel regimens. So given the strong evidence that testing for MRD in patients with AML in remission can stratify them into either a high or a low risk of relapse and survival, so there is great appeal in developing a universal single test which can monitor patients with AML. And it's a potentially unrealistic aspiration, but is motivated by the fact that we have great success in monitoring other blood cancers, such as our chronic myeloid leukemias or our acute promyelocytic leukemias, in which we can monitor the BCR-ABL or the PMR-RARA with molecular PCR testing. Also with our lymphoid malignancies and multiple myeloma, in which a distinct cell surface immunophenotype and clonally rearranged immune receptor provides two ideal options for MRD monitoring. So I'm just going to go through some of the recommendations that the ELN proposed in 2021 with regards to specifically flow cytometry. And immunophenotyping is an essential and readily available tool for diagnosing AML and is currently the most commonly used MRD detection methodology available. An optimal AML-MRD testing strategy for relapse prediction requires the optimization of multiple factors, including intervals between testing time points, the type of sample, whether it be bone marrow versus peripheral blood, and the amount of sample tested. And one must account for AML disease biology and kinetics, as well as patient characteristics that include the age, previous disorders, time points of treatment, and the intensity and nature of the therapy. So the ELN has sort of given recommendations, and they've sort of separated them into 4 different categories, that being the leukemia-associated immunophenotype and difference from normal. They've made recommendations around the technical requirements around sampling and the pre-analytical phase, gating strategies and calculations for flow cytometry, as well as future improvements in MRD. So the principle of immunophenotyping relies on the knowledge of the tight control of the maturation and differentiation of normal hematopoietic cells with consistent expression of cell surface molecules at different stages of maturation. And neoplastic cells lose this regulation, which results in changes in their molecular expression. Now, detection of MRD in flow cytometry uses similar principles to diagnostic immunophenotyping, but requires more sophisticated antibody combinations to detect the very low frequency of leukemic cells within an otherwise normal bone marrow. So the leukemia-associated immunophenotype defines individual-specific surface markers at diagnosis and tracks these in subsequent assessments. And this approach assumes that it assumes the stability of the immunophenotype after therapy. And as we all know, this can change after therapy. The leukemia-associated immunophenotype may cause false negativity if an extended antibody panel is not used. So if we just look at this, sort of if I direct your attention to the table on the right-hand side, this was just an article by Dix et al. Showing measurable residual disease in AML using flow cytometry. And they just showed some of the disadvantages of using the leukemia-associated immunophenotype, such as it's requiring a diagnostic sample, having an extended antibody panel, and does not take into account the phenotypic shifts that happen with post-treatment. And then moving on to the difference from normal. So this focuses on normal blasts and the subsequent identification of blasts which deviate from the normal. The approach relies on the observation that when myeloid cells mature, the change in immunophenotype is very consistent, both in the antigen expressed and in the intensity. And this is disrupted in leukemic blasts, providing a platform to distinguish leukemic blasts from normal blasts. So the difference from normal approach requires access to a normal template that is derived from the normal characterization of normal cells. And such a template should ideally take into consideration the presence of the leukemia-associated immunophenotype that some normal myeloblasts do express, and I'll talk to this in subsequent slides. And using the normal template, phenotypic results from MRD assessment can be superimposed, and thus enabling assessment of whether or not the immature population detected is different from normal, hence residual leukemic blasts. And this does not rely on the stability of the diagnostic leukemia-associated immunophenotype during treatment. So just drawing your attention to this scatter plot on the right over here, where the progenitor gating was done with CD45 and side scatter. And the red shows the normal myeloblasts, and the blue or the dark blue normal lymphocytes, the green neutrophils, the magenta or the purple color monocytes, and the lymphoblasts in the sort of light blue cyan color. And then using the different from normal approach, you can sort of gate it across different fluorophores to see where exactly your blast population is sitting in relation to normal myeloid maturation. So just from this example over here, with the red population being your normal myeloblasts and your dark blue being your leukemic blasts, we can see that using the different from normal approach, that the CD38 is decreased, the CD34 is slightly decreased, the CD123 is increased, and the CD56 is increased, and the CD7 variably increased. And with this approach, you can detect minimal residual disease, measurable residual disease without a diagnostic immunophenotype. So, so this was sort of the recommendations that the ELN proposed. So they proposed that when available, a diagnostic sample is preferred to determine if there is a diagnostic flow cytometry MRD target, and assess monitoring and treatment efficiency on potential clearance of this diagnostic leukemic population. Implementation of a minimum required fluorophore combination is a prerequisite to harmonization. And they do recommend that using a combination of leukemia-associated immunophenotype and different from normal MRD detection, analysis, and reporting. So if you look at from point A to point D, these are the 8 core markers that the ELN has recommended that we use in all of our panels for MRD monitoring. And if there is a monocytic component, to add CD40, CD64, CD11B, and CD4 that may also be relevant. And using these 8 markers, experts could identify a useful leukemia-associated immunophenotype in a range of between 70 to 90% of AML cases. And this was shown in different studies, comprising of several hundred patients, consisting of all WHO AML subtypes except APL. Then they also proposed... yes, sure thing.
Yes, hi, it's Jessica here. We did discuss before that I'm going to just interrupt you for 5 minutes to ask for some input from Theo Gerdener, who, as most people know, he is a very expert flow cytometer in private practice in Gauteng, and also an honorary lecturer with us here at UCT. And he has a meeting that he has to fly off to at 4:30. So I was just hoping that Theo could perhaps switch on and give us his perspectives, how he is running the AML MRD flow in the private sector, and any pearls that he'd like to add or impressions before he needs to leave us. Theo?
Hi, Jessica. Hi, Kingsley. Thanks so much. This is fascinating, and I wish I could have stayed. I'm by certain no stretch of the imagination am I an expert on AML MRD flow, and I don't think anybody is in South Africa, but I agree fully that one has to standardize this. Flow cytometry for AML MRD, we're currently running 12 color panels. It's an ongoing validation. There is considerable overlap between, we use a combination of an LAIP and difference from normal, but I must stress that the difference from normal, there's considerable overlap between rare populations in the bone marrow and malignant cells. So rare dendritic cell subsets and the like can mimic easily leukemic cells. So our validation is ongoing, and definitely I think bioinformatics such as Infinisight or the Cytobank softwares and things which will do this analysis for you helps. But it's a very long validation, and then even when one is running it, it takes very long to report because you have to determine for your assay if a certain phenotype is present and what your lower limit of detection for each phenotype is, and therefore we are running hundreds of normals to try and determine for each abnormal population we find whether that's present in a normal and what one's limit of detection is. So it's certainly not ideal, and it's highly demanding. I'm hoping that someone will bring out a standardized panel, but I know that Euroflow has been struggling with it. Potentially now that they've gone over to the new BD instrument, which is a 10 color, they'll be able to do something. But in the meantime, we are plodding ahead in the dark. And then I'm hoping that Karen Shires is going to give us some hope as well, because the molecular is certainly promising, and there are NGS assays out now which will go for about 40 genes and will pick up a variance in those at a level of sensitivity of 0.1%, which is not great, but is better than nothing. That's my 2 cents. Thank you.
That's very helpful, Theo. Just one question from my side. For samples that are coming from peripheral areas where there may be a long delay, do you recommend any type of RPMI or transfix, or do you just
transfix? We don't. We don't use transfix for this at all. What I can tell you is a bigger problem for us is who is doing that marrow, because oftentimes they are so hemodilute that we're not finding any disease, but even with running 10 million cells or so, our sensitivity is still not good because the sample is just of poor quality. So I think the recommendations also you have to comment on hemodilution, which is extremely important, because you need to tell your doctors that, no, I didn't detect disease, and from a laboratory and analytical point of view, I did everything I could do, but there's still a good chance that you may have missed it because whoever did the marrow gave us a blood contaminated sample.
Very helpful, Theo. Thank you so much for fitting us in before you go to your next meeting. We're going to go back to Kingsley now, who's going to speak to us in more detail about the hows and whens and analysis of MRD flow. Thank you, Theo, and back to Kingsley.
Thank you so much. Okay, so the ELN also recommended that particular attention should be paid to identification of aberrant immunophenotypes in control samples with regards to regenerating bone marrow. And if we do see that there are aberrant immunophenotypes being expressed and we think that it is regenerating or stress hematopoiesis, we should actually write in the report that we think is that, and that a repeat sample should be done within 2 to 4 weeks. That may be informative. And just sort of speaking more a bit around why they actually sort of included these 2 points, is that around about in 2018, 2019, Camberg et al. Published a paper titled Myeloblasting in normal bone marrow expressing leukemia-associated immunophenotypes. And they evaluated the expression of 14 normal bone marrows and found that 5 of them actually had leukemia-associated immunophenotypes. So in a small subset of normal myeloblasts at different stages of differentiation, these myeloblasts actually express markers like CD15, CD11B, CD7, CD56, and CD4. And at the time of that study, they used a 4-color antibody panel with limited cell surface markers. They used 6 markers for the detection of aberrant immunophenotypes. And they showed that a threshold of 0.1 to 0.01 interference of background expression was observed in between 57 to 100% of normal bone marrow samples tested. And these results were not in line with what was recently published in the 2017 ELN guidelines that had a threshold of 0.1 that was recommended as a universal applicable cutoff for MRD. And these authors raised general concerns that about the liberal criteria of the leukemia-associated immunophenotype definition on myeloblasts, and whether the expression percentage on normal myeloblasts might exceed the cutoff of that used in clinical trials. But then the methodology was sort of scrutinized, and Hanekamp et al. Responded to their concerns, saying that it was specific to the presented data in their study, and simply extrapolating these to the most latest, more evolved flow protocols would be suggestive and invalidated diminishment of the ongoing clinical relevance of flow cytometry. So current antibody panels, as recommended by the ELN, actually use more than 8 fluorochromes and at least 9 markers of leukemia-associated immunophenotype assessment, which enables background levels far below 0.1%. And in all of the most recent studies, background expression of normal bone marrow using strict gating strategies ranged between 0.00% and 0.04%, and thus do not interfere with the 0.1% cutoff level for all frequently used leukemia-associated immunophenotype markers. Just moving on to the second category with regards to sampling and pre-analytical phase. So the ELN recommends that the first pool of bone marrow aspirate is used for MRD between 5 and 10 moles, and the process sample should be run within 72 hours, as more than 72 hours may potentially compromise the cell viability. Now, the sample preparation should reliably produce high-quality flow measurements and should be applied consistently across samples. And basic principles of instrument setting using standard operating procedures developed by international flow cytometry consortia such as Euroflow or the US National Institute of Standards and Technology. And like Theo mentioned, explore strategies to assess hemodilution that can be incorporated and reported as part of the MRD assay. So some groups have sort of come up with some formulas for detecting hemodilution, but at the moment, the ELN hasn't sort of identified one formula that can be used across the board, and essentially it's institution-based, which formula they would like to implement in their institution. But at the moment, we don't actually have a definitive best approach to detecting and reporting on hemodilution. Moving on to the third category, gating strategies and calculation for flow MRD. So for clinical decision-making, MRD assessment should be performed with a qualified assay as based on guidelines for rare events in flow cytometry occurring at frequencies of less than or equal to 1%. And using gating syntax, including forward side scatter versus time, as well as doublet exclusion plots. And they did recommend that an additional viability die can be used for further gating. So the standard of determining flow negativity is the acquisition of more than 500,000 CD45 cells and more than 100 viable cells in the blast compartment, assessed for the blast aberrancies available, that giving a sensitivity of between 10 to the minus 3 to 10 to the minus 5 leukemic cells within the white cell compartment. Now, test positivity is defined as anything above 0.1% of the CD45 expressing cells with the target immunophenotype. And this is despite acknowledgement that MRD quantification below 0.1% may still represent residual leukemia. And they also mentioned that the lower limit of detection and the lower limit of quantification should be calculated to assess flow assay performance for each panel combination used. And reporting MRD results without this lower limit of detection information is not meaningful. And each leukemia-associated immunophenotype may have its own background noise that could individually affect the lower limit of detection and the lower limit of quantification, as Theo had just mentioned. So, and then sort of the last bit is that they had future improvements in MRD. So they mentioned an addition of an extra tube that has CD38 in it to look for these leukemic stem cells that are CD34 positive and CD38 low or negative. And then you can add other aberrant markers into this tube. And they recommend that optimally 4 million events should be captured, and this is in a 1-tube assay. They also recommended that high quality flow cytometry data are necessary for future automated analyzers. So assessment of this leukemic stem cells improves the prognostic impact of MRD detection. And these leukemic stem cells are defined as cells that are capable of initiating disease and have the capacity to self-renew. And it is thought that to eradicate leukemia, these leukemic stem cell populations must be eliminated. Now, small populations of these cells may be more therapy resistant than the bulk leukemic cells and form the basis of relapse. And although and they found that these CD34 positive, CD38 negative populations are the most therapy resistant, and increasing numbers are associated with an adverse prognosis. So here we can see that if you are MRD negative as well as LSC negative, it has the best prognosis for the cumulative incidence of relapse and overall survival. And if you are positive in both your MRD and your LSC, it has a dismal prognosis as there's 100% relapse within 3 years. So I'd just like to highlight just sort of like the depth that we actually investigate the patients at diagnosis versus when we actually investigate patients with regards to MRD. So when we have a new leukemia, we usually acquire at least 50,000 events, and most AMLs have a high blast percentage in the peripheral blood, and we don't need to go further. But then this sort of stops us from actually identifying very small subclones that that could possibly express a different immunophenotype than the major clone. And then when we do MRD testing and we sequence and we detect at a very low level of sensitivity, this might actually be a confounder within the actual assessment of MRD. So as previously mentioned, the ELN defines a test positivity of greater than 0.1%. And this threshold guarantees that the leukemia-associated immunophenotype sensitivity in normal and regenerating bone marrow is above the frequency of any background, and is currently the chosen threshold for clinical decision-making. Important to note is that a positive or a negative MRD result refers to the detection or not of measurable disease above specific thresholds that may vary by assay and by laboratory. And it is important to recognize that a negative MRD result does not necessarily indicate disease eradication, but rather represents disease below the assay threshold in the tested sample, and the patient may still experience relapse. And also MRD assays with a non-zero result may still be called negative by the laboratory if the level detected is below the threshold linked to prognosis. So at the moment at Groote Hospital, we capture a total of 2 million events with regards to flow cytometry and AML. And our limit of quantification with regards to our Infinisight software is 200 events at a level of 0.01%. And we use the first two tubes in Euroflow as depicted here on the right-hand side in these red two boxes over here. What we do at GSH is that we look for the leukemia-associated immunophenotype, and we do not do the difference from normal. Now, I'd like, and I possibly stand to be corrected, but as far as I know, within the NHLS, flow cytometry for AML MRD is not accredited across the board. So I guess we are still in the developmental stages of actually getting this assay underway. But we can report on it, but it's just not accredited at the moment. And as Theo mentioned, even in private, they are still trying to validate their assays as well. So just some of the time points for MRD monitoring that the ELN recommended. So I'm not going to go through the molecular bits as Karen will be doing that, but just bone marrow assessment after 2 cycles of induction, at the end of consolidation, and pre and post stem cell transplant if applicable. And thereafter, they recommend 24 months with bone marrow assessment every 3 months or peripheral blood every 4 to 6 weeks. But further research is needed with regard to the sensitivity and the specificity of looking at bone marrow versus peripheral blood. Some definitions of MRD response and relapse. So just sort of the new category, CR with negative MRD, just to highlight that. And then conversion from negative to positive MRD in peripheral blood and bone marrow should be confirmed within 4 weeks in a second consecutive sample, preferably with a bone marrow sample. And available data suggests that patients with 1 positive and 1 negative MRD result from 2 different techniques have a higher relapse risk than patients with 2 negative MRD results, but a lower relapse risk with patients with 2 positive MRD results. Just some advantages and disadvantages. So flow cytometry is applicable in approximately 90% of patients. It has a quick turnaround time of less than a day. A single result is interpretable, but there's still questions around if it is actionable. High specificity when using the leukemia-associated immunophenotype. We can distinguish between live and dead cells. There's ease of storage data and provides information on the whole sample cellularity. But there is a lot of limitations involved as well with regards to the sampling with leukocyte number, cell viability, hemodilution, hyperplasia. and it requires a really experienced pathologist to actually interpret MRD in AML. There's problems with the sensitivities, as well as the phenotype is not stable over time. And across the board, we need harmonization and standardization across laboratories. So I think sort of the gist of it is that conventional cytomorphological CR has a higher risk of relapse and a worse survival if evidence of residual disease is detected by MRD compared to those who test MRD negative. And that AML MRD test positivity is prognostic. But importantly to note is that also MRD test negativity does not equal patient MRD negativity. And select patients such as NPM1 mutations or your core binding factor AMLs may have a prolonged survival, even if MRD is detected at lower limits, such as less than 2%. Patient testing MRD negative by flow cytometry prior to stem cell transplant still has a 20 to 30% relapse rate, and de-intensification of the standard treatment based on an MRD result should only be attempted cautiously and as part of a clinical trial. Some patients with MRD in remission are incompletely treated and have chemosensitive disease left to treat, but alternatively, MRD may reflect the residual chemo-resistant clone, which may or may not be resistant to novel agents. So in conclusion, MRD is rapidly becoming the most powerful predictor of relapse in AML. And multiple studies have shown that those who remain MRD positive at various time points in treatment have a much higher risk of relapse and overall lower survival. As MRD assessment becomes standard of care in AML, understanding the methods available and appropriateness of each patient will be imperative in correctly interpreting the results. And flow cytometry is more widely applicable, but has inherent more subjectivity in the interpretation. The ELN consensus recommendations for the use of flow in MRD assessment are a great step in improving the standardization of flow cytometry, and current limitations of flow are being addressed by different approaches.
What? Yeah.
Sorry, can you mute yourself? Somebody's got their...
Sorry, I don't know how that happened.
New methods of data interrogation, integration of novel markers, and further refinement of the leukemic stem cell population allows for ongoing improvement in sensitivity and applicability, and further research into incorporation of MRD into treatment algorithms and benefit of preemptive interventions are required. And with that, I'd like to thank you guys for listening and open to any questions as well.
Overview. Thank you so much for such a detailed but nice simplified approach to this. Really, that was great. I'm just going to start by inviting some comments from Almaru Dupasani, who is joining us online. He is also one of our alma mater, who graduated in 2009 and left us for pathcare in 2014, almost 10 years ago, where he's actually very senior in flow cytometry, I think running the flow cytometry, and in fact, his MMed was also in AML, flow cytometry and AML. So that is his particular area of interest. Almaru, we would really appreciate your comments, as well as regarding the different queries we have, things like, you know, how we can stabilize samples for transport, and how you deal with this issue of how, you know, the draws and when we actually perform the mirror, the practical aspects of how much to collect and how we do that. Thanks very much.
Yeah. I just want to start off. Jessica, can you hear me? Can you hear me?
Yes, we can hear you.
Yeah,
Perfect,
okay, great.
perfectly, thank you.
Sorry. Yeah, look, I want to start off with, again, like Theo is saying, with a disclaimer that I'm by no means an expert on flow cytometry at all. When it comes to MRD and AML, it is really hard. I don't think we should sort of beat around the bush by saying anything different to it. Maybe international experts find it a little bit more easy or make it look easy. For me in particular, it is pretty hard, and we often rely on the leukemia-associated immunophenotype and quite heavily on the diagnostic sample, the initial flow cytometry that was done on that to compare. We do look at some normals, but I mean, most of it comes down to leukemia-associated immunophenotypes. I think the testament to all of this, why it is that it is hard, is why the Euroflow consortium hasn't brought out their own, fully completed MRD, essentially kit-based assays, and that kind of tells some degree of the story. It's difficult. When it comes to sampling, again, I share Theo's sentiments, and he's saying when it's sent from afar, but I can basically vouch for when I do the bone marrow biopsy, it's not always that easy to get a very rich sample. You've got a patient that is experiencing a bit of pain, discomfort, and so forth, and even in private, we don't have the facilities to sedate every single patient. That means an admission, it means saturation monitors, it means a sedationist, et cetera, and it adds an enormous amount of cost to the whole procedure. But I appreciate that is important, but it's not always a viable option to do. And if we are aiming to take 5 to 10 moles of sample as a first draw sample for MRD, that's quite a lot of bone marrow, and it depends on the patient. So I basically make a call on whether this patient can tolerate it or not, in terms of how much I really do take in the end. I do take my first draw sample for my MRD if it is clearly written in the form that was the purpose for the assessment, which we don't always know. We don't always know which point in time this is. Sometimes we do, sometimes we don't. The problem with that is it's a bit disconcerting for the older school, and basically your morphology is rendered pretty much useless, because the samples that you're making smears from is completely dilute and useless. So mostly I pretty much can't report on the aspirate afterwards, which is I know it's not the primary purpose of that, but it's very disconcerting for somebody that is used to that, to have a rich sample first and then report on the flow cytometry. The flow cytometry I can't see; I can only see dots on the screen afterwards. So it's a complicated issue. I do try and take at least 5 mol, and then do my smear afterwards, and depending on my customer, I may do more. In terms of fixatives, I'm not very keen on the transfix idea, because I inherently feel that when you add a fixative, and you may have had a fixative on your diagnostic marrow, that it does change the way that the antibodies bind and the intensity of the fluorochrome. Although it's still acceptable in diagnostic samples, I'm not entirely convinced that this should be done in an MRD sample where you're really looking for a needle in a haystack. When it comes to that, I would rather get the sample to the lab as quickly as I possibly can. That said, we transport samples over relatively great distances. We've got samples coming from Namibia, for instance, sometimes, and generally it can reach the lab within 24 hours. However, then a whole batch sits at the border, and there's some kind of logistical issues, permit issues, etc. And all of a sudden you've got a sample that is, 48 hours to 3 days old. I think this recommendation of less than 72 hours is actually a bit high already, and you can see quite a lot of degradation of your sample. I would say not more than 2 days, but again, one has to do what you can do. Yeah, so from a transfix point of view, I've tried it a few times on samples, and I'm not a great fan of that. That is, I don't know if there's anybody else with any comments on that. Let me just see if there's any other questions on the chat.
Omri, what about RPMI? Was that something that's possibility for stabilizing?
Yeah, look, RPMI, again, I don't like adding anything if I can prevent it from happening. Where I add RPMI is usually with FNAs, where that it's a very kind of dry sample that goes into an EDTA tube, and it and the cells really start to die very rapidly. My CSFs sometimes add RPMI to it. But I haven't really tried RPMI for MRD per se. So I've mainly used it for CSFs, just to make those or keep those cells alive for a little bit longer. We're still talking about doing the assay within hours. So for the CSF samples, I would first prize, get them there within the hour. If it's going to take up to 12 hours, I would add RPMI to it and cross my fingers and hope I've got a viable sample still arriving. For transfix, yeah, I mean, I think again, if you're transporting samples over great distances, it's probably better than nothing. So when it kind of reaches, it's going to take more than 24 hours. For diagnostic samples, it's perfectly fine. You're not going to have any troubles. I'm just not sure about the MRD samples. I've tried it with transfix and RPMI for normal diagnostic samples, but not really ever for MRD samples, just because it just looks a little bit different. And because it's already hard to look at these, I don't want to have any kind of artifactual changes that happens. We see it with the EQA samples, where these are typically stabilized samples, and they look different. And they often send you a diagnostic immunophenotype, which is also then fixated in the same substance. So it's not that difficult to compare, because you've got a fixated sample versus another fixated sample. But often you've got a diagnostic sample that is not, and then your MRD then that is. So that is where the trouble starts. And also if you're going to run normals and compare normal to a fixated abnormal sample, I'm not. It's gonna create more issues. But yeah, it's difficult in a country as big as ours, with transporting samples over vast distances. There's certainly no ideal answer specifically to that. I was hoping molecular will just take over and completely run with AML MRD. It hasn't quite happened yet, but I'm very hopeful, and I'm holding my thumbs for Karen Shires to tell us all about it.
Yeah, so Karen is going to be speaking next, but I just wanted to finish off with this issue of the volume of sample, because even though these ELN guidelines state 5 to 10 mils, I don't think anyone's doing that in practice. My understanding was just 1 5 mil tube. I think where possible, if you can just, put your needle into a different, slightly remove it and put it in for a second aspirate for your other samples, I think that probably is optimal. But yeah, I mean, unless anybody else has anything more on that.
Just
Kingsley?
sorry.
Yeah, go ahead, Omri. Yes.
No. Just what I have done is sometimes I've taken my needle, not necessarily in a different spot, but just pushed it 2 centimeters. If you've got space, push it a little bit deeper.
Yes.
Just accessing different space, not necessarily
Yes.
making another hole.
Yes.
But again, it's so variable in terms of what your customer. So I judge my customer by how they perform, and whether they can take this or not. And unfortunately, you have to work around that as well. You've got a person lying on the bed there, and yeah.
Yeah, okay, great. Thank you. Thank you very much, Amru, and everybody for the comments on the flow cytometry. We're going to be moving on to the second part of the talk now. I know there are some questions regarding molecular issues. So I'm going to hand over to Karen, who is an associate professor in our department. She is a principal medical scientist in the NHLS and is a molecular hematologist. So this is really her area of focus and interest. Karen, we are delighted to have you to speak to us about the pros and cons and ifs and whats of molecular testing in AML MRD. So over to you.
Thank you very much. I don't know if everybody can see my first slide. This might be a disappointing talk. This might be a disappointing talk for many people.
I can see it. Thank you.
Yeah, the shark lurking in the dark, the murky, dirty waters. Unfortunately, molecular MRD monitoring AML, we're not there yet, but I definitely think hearing about all the troubles with the flow cytometry and the way things are exploding on the molecular front, I definitely think it's going to be the way to go. And I think that as soon as we have some kind of standardization, it's actually going to go quite quick. So it's definitely going to be one of those watch this space kind of issues. But I kind of just wanted, because I on those talks that I put online, the last one I did was 2021. It was just before the new ELN guidelines came out. So this is kind of an update. So I haven't gone, I haven't done as nice a job as Kingsley did, but I just kind of want to point out some of the potential issues with molecular monitoring at the moment in AML. So, oops. Okay, so as Kingsley said, basically now saying that MRD molecular assessment should actually be standard of care for AML. But unfortunately, we're not there yet. It's like the cart before the horse. We've got many questions that are unanswered on the practical side, and all which will actually impact the quality and interpretation of a result. We're getting there, but we're not ready yet. And I actually attended an online kind of seminar series end of last year called Best Practice and Standardization of Molecular MRD in Leukemia. And while the ALLs are actually, that's kind of not looking too bad at the moment, and NGS is playing a huge role in that, and it's actually the standardization around MRD and ALL looks good. Because AML is such a complex, heterogeneous group of diseases, which I think might be the fundamental problem, it is a lot more difficult to obviously start standardizing things on that front. But so I basically just want to, in terms of the things on the practical side that just molecular in general, we are going to experience with this, and also what came up in this seminar as to the things we don't know yet and still need to figure out. So the first one is even as basic as what markers can actually be used. And Kingsley had, I think it was on the first slide or second slide, that long list of molecular abnormalities in AML, and unfortunately they're not all suitable for MRD monitoring, and there are only ones that have actually been kind of shown to have any kind of clinical value in terms of this being positive or negative. And the nice one that has been added actually quite recently really is this whole concept of monitoring mutated NPM1 transcripts. You've obviously got your APL, your 1517 translocation, and then your 821 and your inversion 16 transcripts. Unfortunately, a lot of the other rearrangements and a lot of the other translocations are not faring so well in showing any kind of nice patterns or any clearly defined kind of clinical outcomes. Down at the bottom here are, while actually many years ago, it was considered that we should be looking at expression levels of WT1, PET2, some of the RAS and the IDH1 and 2, but they were found to be not suitable targets because of the fact that they're secondary usually to the fundamental kind of pathogenic mutation, and they can occur in subclones. So that means that those subclones can disappear if they're not fit enough, especially in the kind of clones that have managed to avoid the chemotherapy approach and are sitting there in the bone marrow microenvironment. But one that was that has kind of caused me a little bit of concern is that FLT3 is now being, whether you're looking at ITD mutations or the tyrosine kinase mutations, that is now being touted as a great molecular target for MRD. And I was so happy that I wasn't the only one that thought that this was a bad idea. So at the seminar that we were at, people were raising the point that this is really not a great target. It's been long known that it is a secondary mutation, that you can have clones that become negative. They don't become negative, you lose those FLT3 positive clones. And even at the Heme conference in October, it's life of me, I'm not very good with names. I can't remember the international speaker, but it's showing, trial after trial, FLT3 negative, and isn't that wonderful? But yet it's actually now being clearly shown that they have these kind of mutations, including FLT3, have very low negative predictive value. So in other words, if you don't see it, if you can't detect low levels of them, it doesn't mean, it actually means very little. So they only have predictive value if you can actually detect them. It is being, UK NECAS is now thinking about trialing whether or not, we should be starting to look for the FLT3 ITD mutations. Definitely not an easy thing to do for MRD because you have to make them patient specific. But at the moment, we're limited to 4. But I think as more tools, kind of like molecular monitoring, are kind of put into use in clinical trials, we're going to get a lot more information about what happens through the disease progression and what molecular kind of signatures are important moving forward. So I would definitely say watch this space in terms of the number of AML subtypes that we can actually monitor via MRD. I think is going to increase substantially. I'm going to need an extra 5 million pairs of hands. There are, however, some really basic fundamental issues when it comes to this, and these are issues that have been raised already, and obviously the same issues that the flow cytometry suffers from. And the big one being, we'll be looking at bone marrow or peripheral blood, and obviously peripheral blood is very useful as kind of seems to be very useful from a leukemic point of view in terms of when our molecular methodologies are incredibly sensitive, over like 5 logs of disease. So if you have a circulating kind of disease population, like you do in CML, for instance, peripheral blood is a perfect kind of target for that, makes it a lot easier. But in AML, obviously, you have low-level residual disease that doesn't necessarily circulate, so it's sitting there in the bone marrow. Unfortunately, then your peripheral blood then is not very sensitive. It can't, you're not looking at that residual disease component. So your level of kind of MRD detection is, 10 to 20 times less sensitive than using the bone marrow. However, having said that, if you start monitoring patient at diagnosis with peripheral blood, you technically can still use peripheral blood until your patient is peripheral blood MRD negative, and only then go and look in the bone marrow. So that may save your patient a couple of unnecessary stabs. But the bone marrow is obviously still regarded as the best place to look for residual disease. But if you look back in the day, with CML, bone marrow was as well. And, we just don't do that anymore. The problem is obviously you can't assay a patient every month. And I put the boxing match because there's been a lot of conversation here about this first pull. Well, you know, molecular are going to want that too. So I'm not quite sure how that's going to work. What was of interest came up in this symposium, seminar series, whatever, was should we actually maybe be sorting the cells? So that would be a way of kind of trying to clean up a bit the whole hemodilution issue, also trying to get rid of lymphocytes and things and only look at the myeloid cell component. You know, should this be a way of maybe increasing sensitivity and kind of giving us a more stable sample? Not easy in a diagnostic lab routinely to do this. But one thing that definitely was talked about a lot was that obviously, you know, bone marrow is a problem in terms of it being patchy disease. And, you know, especially whereabouts in the body you take it from can be an issue. And there was one study, and unfortunately, I can't for the life of me find it. I will find it and maybe send it to you. Is when there was a group that were actually presented at this symposium, and they were looking at levels of NPM1 mutated transcript, and they found that it made a humongous difference even which side of kind of where exactly they put the needle as to, and the aspirate that they got out of these poor patients who were being used as guinea pigs. Up to, you know, 10-fold differences in the levels of NPM1 transcripts. And obviously clearly then also, you know, some samples from the same patient that were positive and some were negative. So I think we're going to have to move away from bone marrow and because it's not actually a reliable molecular kind of source. The problem is that a lot of the current data talking about, like, you know, you need a 3-log reduction or defining what is in terms of MRD positive and negativity and setting any kind of limits, actually the literature is full of studies that have mixed sample sources. So some of them have been using peripheral blood, some have been using bone marrow, some have been sorting the cells. So at the moment, the literature is full of some very kind of confusing data in terms of what is relevant and what is not. And I think the meta data analysis, those large kind of studies looking at all the studies, have to be very careful in trying to pick apart the methodologies, and I'm not convinced that they've been doing that. So when it comes to, you know, at what points should you actually be looking for molecular, at least, evidence of MRD? And it's definitely, obviously, starting to become apparent, which I'm not surprised, is that one size does not fit all. So something like APL, there is no point looking just after induction. You really need to be looking at post-consolidation. And then really shouldn't be monitoring for longer than about 2 years. I must say, we've monitored a lot of patients and some for very much longer than that. And the relapse, if you're going to have one, which is also very rare with APL, occurs within the first year. So this, you know, bone marrowing your patient for 5 years is a bit unnecessary. But then when it comes to things like AML with NPM1 mutations, you want to be looking after 2 cycles of chemotherapy because you want to see a rapid response. So you don't have to see molecular negativity at this point, but you want to see like a log reduction in the levels. Then obviously this post-consolidation phase is prognostic in this particular AML. And then again, you want to be monitoring every 3 months to watch for potential relapse. And it's pretty much the same with the, sorry, say 821. But here it's recommended to be using peripheral blood. So at the moment, it's all over the place. And what we've kind of been doing and suggesting is to kind of, if you can actually spare both in terms of do peripheral blood and bone marrow at the same time, and maybe peripheral blood in between bone marrows so that you can have some kind of indication as to what's going on. My gut feel, I think, would be to do bone marrow, would be to do peripheral blood at diagnosis to make sure you can actually detect what you want to detect. and then do peripheral blood at those various time points until you get MRD negativity, and then do bone marrow. So the molecular kind of methodologies, so NGS, and you know, I've never been a fan of NGS. I'm going to have to get into NGS. Jessica, yes, I know. For ALL, I'm very keen on it. You know, in ALL, the NGS has been well sorted out. You're looking at single gene targets. It's incredibly reproducible and very useful. We're not there yet when it comes to the myeloid kind of malignancies. It's currently not sensitive enough. 0.1% is the best you're going to get on some of the limited panels. It's not good enough. And also, it's very prone to low-level contamination. So it requires method changes from how you would, from if you're just going to be using it as a diagnostic panel. So you kind of have to be in a different mindset to use it for that. So the recommendation still by the ELN is that it should not be used as a standalone MRD method, and I think I would agree with that. However, in the right-hand corner, I do have a little picture there saying, in the future, I think this is going to be the way to go, because I think it has, once it's a bit more refined, it has the ability to give good depth, so and give a lot more information at the same time. So we might end up looking at multiple targets and things, you know, 2 or 3 or 4 or 5, maybe even potential transcripts at the same time. So I think this will be the way to go, but we're still not there yet. Real-time PCR, quantitative PCR, and I'm not even going to mention droplet PCR, digital PCR, because that's also kind of falling into the NGS category. We don't have enough information yet on how reliable it is. But in 2003, a group, Gabbard et al., were part of the ELN standardization of targets and PCR approach for quantifying and monitoring leukemic transcripts. That was back in 2003. So the ELN, I did read the 2021 guidelines, quite happily say that, you know, this qPCR is standardized and stuff. Well, no, not anymore, unfortunately. There has been a lot of development in terms of technology, methodology, being able to, you know, the machines that we've got now are capable of so much more than back in 2003, that the idea of kind of doing this laborious absolute quantification in separate tubes and then having plasmid standards and stuff, which all that was based on, is really, you know, especially for these rare AMLs, it's just not, you know, you're just not going to even cover the costs. So we definitely need a new standardization approach that at least allows smaller labs to use equipment and methodology that is more cost efficient. So the other big thing is that there are no established EQA programs. There are a few in pilot phase. NECAS started one last year that looks at like 821, inversion 16. You've also got the MPN1 transcripts, type A only transcripts, looking at basically like 3 and 4 log reductions, but that literally has started last year. So they're not accredited yet. So these EQA programs are absolutely essential if you want to provide a quality service. The other thing that is, I think, quite critical, that the ELN making some very strange cutoff. So I saw what Kingsley gave his now, that you have in flow, you've got the 0.1% cutoff. Well, instead of that, for some reason, the ELN committee or whatever else have given this MRD molecular cutoff in terms of crossing points on a real-time PCR image of 40. Being above or below that will give you MRD positive or negativity. And that really is based on QIAGEN tests. So QIAGEN many years ago came out with, in fact, they were part of the team that was working with Gabbard et al. So they kind of, this ELN, it's kind of become a bit of a, I don't know, inbred is the wrong word, but they're all kind of feeding off one another, and I think it is way too prescriptive. So the CT value of 40 honestly means absolutely nothing unless you are using the Qiagen specific test. So that needs to change. And another thing is that the transcripts can be very unstable. Like the NPM1 transcript, for instance, is incredibly unstable. It lasts about 4 to 5 hours, as opposed to the beta-ABL, which is stable for about 24 to 48 hours. So sample stability, transport become a huge issue, and those are things that need to be worked on. I think this might be, this is just showing that this was the old-fashioned, which we still use the beta-ABL to some extent, the old standardized assay design, which we honestly can't afford to do in our smaller labs. I mean, the NHLS are not small, but you know, you can't. It can cost you up to 10,000 Rand to kind of set this up for one patient. It's not worth it. So we're actually using a novel multiplex approach to do that. But then reporting becomes difficult when the ELN are kind of using Qiagen as their, you know, their kind of standard, if is the right word. So I think I've just got 2 slides left. So reporting and clinical relevance issues, I get asked a lot about this, especially with monitoring the 821s. So this is where it's all a bit still in the air, and I think that we are a couple of years away where we need some clinical trials going forward, kind of using these molecular tools in terms of, you know, being able to, instead of retrospectively, but you know, prospectively looking at levels of molecular transcripts that actually have relevance. At the moment, the ultimate goal obviously is to see a reduction below detectable levels. But what does that mean? So instead of saying, you know, MRD positive or negative is based on this crossing point value, which really for me is very problematic, they should be saying that your assay, it should be at least 3 logs, or it should be at least 4 logs or 5 logs that you can detect disease. How MRD positivity is reported is obviously is also a bit skewed at this point. So at the moment, it's been reported as the target transcript copy number as a ratio of that, the housekeeping gene, which is the old way of kind of doing all these assays, and that limits the types of assays you can use, which I think is really, we're going to have to move away from that, because there's just, it's exploding in terms of the different methodologies we have. And obviously things like NGS and digital PCR can't do this, so that also limits their applications. The thing, the big problem I have with this is this reporting of ratio percentages, is that because of our experience with beta-ABL in CML, where the ratio percentage is the equivalent of a disease percentage. So if you've got a ratio of 50% for beta-ABL to ABL, that is the equivalent of having 50% mutated cells, because it's the number of transcripts beta-ABL to ABL is 1-to-1. However, that's the only one where it's 1-to-1. So if things get reported as a percentage, it's a ratio percentage, I think a lot of clinicians, and I don't blame them at all, misinterpret that as the level of disease, and it's not the case. So if you are looking at an AML with an NPM1 mutation, for instance, if you have 100% blasts, that actually would equate to a ratio percentage of 1,000%. Because there are 10 transcripts of NPM1, mutated NPM1 to every ABL. This can be very misleading when it comes to this. There's a cutoff, for instance, for 2% NPM1 positivity actually means 0.2% disease. So you have to be very aware of what is actually being reported. And on the other end of the scale, there's a very low the ratio of PMRR to ABL as 0. Well, it's 1 to 5. So 100% disease is actually only 20% PML RARA able. So you need to be aware of that, and it can be very misleading. The other thing as well is that it's not easy to compare levels between labs because we are using different things, and the only way they got that right with BCR-ABL in CML was we had this conversion factor. Well, we don't have that for any of these. So you really do need to stick to one lab and kind of use it like that. Sorry, I just want to, okay. So basically, when you're looking at the MRD assessment, kind of the simplification of the whole thing is that if it's MRD positive molecular, I've written it wrong way around. MRD positive means bad, and MRD negative means good. Well, unfortunately, it's really not that simple, as they've shown that, and Kingsley also referred to it, that you can have persistent low-level positivity where there's a relatively low risk of relapse, and in fact, they actually have prolonged survival compared to other groups, and it's not even it's actually comparable in some cases to your MRD negative patients. So, and your but obviously, if you basically are not getting a serious log reduction or multiple log reductions in your molecular levels, then that is definitely is a high risk of relapse and a low overall survival. So as I've said, yeah. So, and the other thing is that things like post-transplant, you know, what should you be looking for? Well, you would assume that everything is negative, but they've actually have studies shown that in the A21s, you often have a low level positive even after transplant. So that could be anywhere, you know, what is a low level positive? Well, that could be anywhere hovering around 0.01% disease or even lower. And is that okay? As long as you don't see an increase, that there's potentially immune control of the mutant clone. So these things are actually quite confusing. And I think at this juncture, it's a matter of kind of looking to see if your patient has the first few doses of chemotherapy, after consolidation phase, before transplant, after transplant, looking at these key points so you have some indication as to what is going on. And again, things like, so this is actually an NPM1 graph showing what was happening in the bone marrow and the peripheral blood. And you can see, obviously, you have a good 5-fold level difference in the peripheral blood. And you are looking for this, obviously, after induction, you are looking for, you know, a 3 to 4, 5 log reduction in your disease burden, which is what you want to see. And you don't want to be seeing an increase because that's going to be a high risk of relapse. So the take-home message from what I've done a lot of reading on, and also with the ELN, is that if you do have an MRD molecular marker, it's very important to determine the ratio at diagnosis so that you have something to compare it to. It's also really important that you know that this molecular marker is actually detectable by the assay that's been used in a particular lab. It really, you know, even if you are maybe a week into treatment, I would still send it so you have some indication as to where you are, you have something to compare it to. Monitor the transcript levels where appropriate. Bone marrow is still being recommended generally, but just from what I've seen, I think the peripheral blood until it's negative is probably not a bad option. And you're obviously looking for a reduction in levels, and you want large logarithmic reductions, and you don't want to see any increases. But what you're supposed to actually do with that information, when you're supposed to intervene, what you're supposed to do, doesn't seem to be very clear. But it does, it obviously helps in terms of risk stratifying your patients and being able to give some feedback in terms of overall management of your patients. The things in red are really key, is that make sure that you pick a lab that can actually detect the AML transcripts of interest in this 4 to 5 log range. That's really important, so you get a good deep response. Don't alternate between labs for monitoring because we're not standardized and the ratios will differ. And remember that the number that you're going to get with ratio percentage is not equivalent to the amount of disease cells. So to bear that in mind. And that finally, that detection of low levels of transcript is not necessarily an overall poor prognosis. It depends on the sensitivity of the particular assay that's being used, and it depends on the AML subtype. And this is all a new concept, and I think we've still got a lot of learning to do, but definitely do it. So my first slide, we introduced the NPM1 type A quantification, which we're doing. We actually passed the EQA, which I was very proud of last year. So we're on the right track for that, and we'll be using the same methodology. We're using a much cheaper approach. We'll be doing that with the 821s in the next 2 months, but also we also obviously offer the 1517 for APL and BCR-ABL as well for the AMLs. So we're getting there, but I think it's going to be one of those things of watch this space. Yeah, but unfortunately it's not that clear cut. So that's me.
Karen,
Hello.
thank you. This was, hello, I'm here.
Hello.
Yes, I'm just unmuting myself. I wanted to say thank you very much for a really, really nice presentation. You gave a very nice overview of really the pros and cons, and I totally agree with your first slide, the murky water and the big shark. And
Unfortunately, yeah.
Yes, what we need to watch out for. But this talk was really great and complemented Kingsley's talk so nicely. So Kingsley, if you can put your camera on as well. We've come to the end of our hour. And I really do echo what the comments are, these comments in the chat. These are really exceptional presentations today. I really enjoyed it, and I think our audience enjoyed it, and very practical. I think there are possibly some questions that haven't been answered. Please do feel free to contact the speakers. Or
Please
Estelle,
do.
if you have any questions or further comments. And I'd like to just wish everybody a great evening and a great week ahead. And thanks very much once again for organizing this forum, Estelle and Claudine and the Blood SA team. Thank you very much.
Thanks everybody.
Bye.
Thanks.
so much.
Bye.
And let's keep talking about it.
Okay. Bye.
Yeah.